Another patient with the pulmonary edema shows a busy hilus, prominent hilar shadows with linear densities that radiate from the hila, representing the axial connective tissue, which appears thickened as a result of interstitial pulmonary edema. This is a close-up of the right base of a patient who had interstitial pulmonary edema. Note that we see lines that run perpendicular to the chest wall. They do not taper as they reach the edge of the lung. They do not branch, and therefore they do not represent vascular markings of the lung. There is some degree of vascular engorgement, which usually accompanies interstitial pulmonary edema. These are the so-called curly B lines. When these lines crisscross, they form a mesh, and they have been called the curly C lines. When they parallel the domes of the diaphragm or parallel the chest wall, they usually represent a thickening of the visceral pleura, the connective tissue at that level, and have been called the curly D lines. This is a photomicrograph showing a thickened interalveolar septa because of edema, and these are examples of the curly B lines. Note that they rise from the edge of the lung and extend perpendicular to the surface of the lung. So the curly B lines and the C lines simply represent thickened interalveolar septa. The thickening can be due to edema, can be due to connective tissue, can be due to particle deposition, but they're not related to vascular structures, although in the pathogenesis of the thickening, there may be obstruction of lymphatics and or obstruction of pulmonary venules. In this patient with interstitial pulmonary edema, secondary to left ventricular failure, we see all the A, B, and C lines. The A radiate from the hila, like a sunburst. The B are horizontal lines in the lower portions of the lung, and they run usually perpendicular to the chest wall. And the C represents a reticulum due to the crisscrossing of the secondary lobules of the lung, the septa surrounding them. In this lateral view of the chest, we see a busy vascular pattern as well as a number of lines that do not correspond to vessels because they do not branch and they do not taper. This patient had interstitial pulmonary edema with both A as well as B lines of curly. Bronchial coughing are the result of a thickened wall of a bronchus. As previously described, they can appear as rings when seen on end, and when seen en face, they produce trem lines. A second stage of pulmonary edema is alveolar edema. In the first stage, interestingly, clinically, there may be no auscultatory findings. But now, when fluid is observed within the lung parenchyma, that is, when it fills the alveoli, we should be able to observe on auscultation rales that are best heard in the lung bases. The distribution of alveolar edema varies, and in this particular case, we can see it in the posterior segment of the right upper lobe. Note that we note the perivascular haziness and the prominence of the left hilus. When we note focal pulmonary edema, often it is not possible to differentiate from alveolar hemorrhage or from pneumonia. However, the change in the anatomical position of the density with the change in the position of the patient will allow differentiation of edema from hemorrhage and pneumonia or other pathological conditions.